The second Gallen meeting, I addressed the topic of extended endocrine therapy in the era of surgery de-escalation. And as we know, estrogen receptor positive breast cancer is a breast cancer where recurrences continue to occur for many years. But two-thirds of the recurrence, half of the recurrence, and about two-thirds of the deaths occur after year 5. And studies such as the overview analysis have shown that individual patient characteristics at the time of diagnosis actually predict for different rates of recurrence over the next 20 years. So having positive nodes or have high-grade tumors or have higher-sized tumors lead to higher recurrence rates, but they continue on the same rate for many years. So over the years, we have explored many strategies to extend adjuvant therapy beyond the 5 years. So many studies have shown that extending tamoxifen to 10 years, or introducing an aromatase inhibitor for 5 years after 5 years of tamoxifen, or extending the aromatase inhibitor use to close to 10 years or 7 to 8 years results in significant improvements in outcome. However, the absolute differences in outcome are still modest, to the range of maybe 3, 4, 5%. So the majority of the patients potentially may not receive benefit from extended endocrine therapy, but they're subjected to additional 5 years of treatment either with tamoxifen or aromatase inhibitor. So one of the topics that I discussed at the meeting was how we can tailor extended endocrine therapy for patients that get the most benefit and avoid it in patients that do not. And we have several approaches in this. We have used clinical pathologic algorithms, as I said before. For example, factors like the age of the patient, the tumor size, nodal status, grade, to estimate risk of late recurrence, and then subsequently change our strategy. And of course, that's what surgical de-escalation comes into place, because now for many years now, we have given up doing axillary dissections for patients with 1 to 2 or 1 to 3 positive nodes based on several randomized trials. So you don't know for sure if you do a sentinel lymph node biopsy and you have 1 or 2 or 3 sentinel nodes that you wouldn't have 4 or more positive nodes if you did an axillary dissection. And of course, we don't do that anymore. So now we have to deal with the fact that in some patients, we were not quite sure how much the risk for recurrence was because we didn't do the full axillary surgery. Now, there's ways to adjust for that because in general, depending on the number of removed lymph nodes, depending on the number of positive sentinel lymph nodes, depending on the tumor size, the rate of having 4 positive nodes goes higher. Overall, it's about a 15%, but it can be up to 50 or 70% if, let's say, you had 3 out of 3 positive sentinel nodes. So we can use this information to adjust a little bit our models. That's one strategy. Another strategy, of course, is to use genomic classifiers to determine risk of late recurrence. And there are several genomic classifiers that are used for estimating risk of early recurrence in the first 5 years. And most of those also predict for risk of late recurrence. So we can use that information as well, particularly if we don't have the full information from nodal status to make the decision, are you at high risk of recurrence and receive an extended endocrine therapy or not? The other thing that is emerging nowadays is also circulating tumor cells, circulating DNA. This is essentially an extension of the anatomic risk to what we're finding out, meaning that patients that have circulating DNA have much worse prognosis, but invariably these patients eventually will go on to distant recurrence, clinical distant recurrence. So the question is, can we help them at the time where we identify a circulating DNA to change the course of treatment? And we haven't proven that yet. But certainly, in the future, many studies may use this circulating tumor DNA information to make the decision if the patient should continue on therapy. Because let's say you have a patient that is taking 5 years of endocrine therapy, and around year 4 or so, you start doing circulating DNA, and you find out this patient is positive, and then continue to stay positive, then you don't want to de-escalate this patient. You don't want to stop the treatment. On the opposite side, it may be that if you have a patient that tests negative for circulating DNA, and at that point, you may say, well, maybe you don't need to take extended endocrine therapy. The problem, of course, with ER-positive patients is that ctDNA can be negative at one point, but it can be positive at another point. So you have to be very careful, and we haven't still figured out what to do best. about that. But that's an emerging field. The other approach, of course, we have taken is to look at some of the genomic classifiers that predict benefit from extended endocrine therapy. There's some classifiers, particularly the breast cancer index, the H/I ratio, as we call it, the homeobox13 interleukin 17B receptor ratio, that in several studies have shown that the high H/I ratio predicts for higher benefit from extended endocrine therapy, and the low ratio actually predicts of almost no benefit from extended endocrine therapy. So predictive biomarkers are very important, but most of the information we have is with a BCI. We don't have any other biomarkers. Now, more recently, some evidence started to emerge with another marker, Mamounas, that we evaluated in 2 studies. One was our own B42 clinical trial that evaluated 5 years of extended letrozole therapy versus none, and showed that for patients with a low Mamounas, there was a trend towards more benefit from the extended endocrine therapy. And these results were also validated in another trial, the IDEAL trial, that compared 2 years of extended endocrine therapy versus 5, and in that trial also they found the same thing, that the low Mamounas potentially showed more benefit from the 5 years versus the 2 years. So that can help us also tailor how long we should give the extended therapy. Should we do 2 years or should we do 5 years? Overall, the trial data show that 2 years of extended endocrine therapy is very close to 5 years, so there's not much more benefit. But then on the other hand, studies have shown that 5 years compared to nothing showed benefit, or about a 20% reduction. So the question is, how many do you give 2 more years or 3 more years, or how many do you go to 5? And potentially Mamounas can help in that based on the data we have so far. So if it's low Mamounas, extend it to 5 years. If it's high Mamounas, maybe 2 years if it's high risk. And of course, again, as I said before, you can use the clinical pathologic factors to determine how much risk of recurrence. Pretty much for patients that are positive nodes, even 1 to 3, we typically would recommend extended endocrine therapy. Unless it's only one lymph node, and then again you did it with an axial dissection, or you don't expect to be positive if you did an axial dissection, and you can potentially de-escalate, particularly if the predictive biomarker says that you're not going to get much benefit from the therapy. So that essentially was my talk in the St. Gallen meeting.